Hi, very good afternoon, everyone. Thanks for actually joining the session this afternoon. I'm Weng Dong. I will be the moderator for the Facebook live chat session today. So today is very happy to actually have Dr. Hwee Seng. He actually a consultant respiratory physician from the respiratory practice in Mount Alvernia Hospital. So he is definitely one of the experts here in Singapore. Especially, I think some of his key interests is actually on the asthma management and how to actually improve asthma care for our patients. So I will say that today the topic actually is pretty relevant for most of us because the title actually is to know more about the asthma management. And why I'm saying so is because we know that asthma is one of the most common chronic disease which is affecting the populations. So just in Singapore, we are estimating about 5% of the adult and actually as high as almost actually 20% of the children actually suffering from asthma. Yeah. So I believe that for today's sections, there's a lot of sharing that Dr. Yip will be actually making. So yeah. So I will say that I think let's in case you have any questions. So this is Facebook Live, so you can actually leave your comments under the chat box behind. Then actually I will raise it to Dr. Yip to answer. Okay. So hi, Dr. Yip.
Hello, Wing Tong. Hello, everyone.
Yeah. So I think while we are waiting for some of the questions to come in, perhaps you can actually share with us what is your thinking about the incidence of asthma in Singapore. As I mentioned earlier, there's actually the prevalence according to the statistics, it definitely is very high. So what is your thought on this, and how often actually you see asthma patients walk into clinics?
So I think the official numbers about for adults, as you mentioned earlier in Singapore, is about 5% of the population, and in children it goes up to about 20%. Now, these numbers are typically high in more developed world countries, as opposed to say areas such as a rural community. And there are few reasons that are thought to be the reason to be behind this. One is the belief that with urbanization, our kids not exposed to allergens at a young age, and they hence develop allergic features, or what we call atopy. And this is thought to be a possible driver to leading to asthma later in their lives. Of course, there is also the fact that in a more developed or urbanized society or country, the ability to access to healthcare is higher. The ability to pick up more asthma is probably also higher. And that probably also reflects to some extent the differences in asthma prevalence rates across the population.
Okay, I believe that what you mentioned actually is the hygiene theory, right? When we talk about allergy and hypersensitivity, a lot of people are actually referring to the hygiene theory. So I think that linked to a next question. So is asthma an allergy? Because I think there's a lot of misconceptions among the patients whether asthma is considered an allergy response or not.
So the difference, I guess, when we talk about asthma versus allergies, allergies we usually refer to a specific inciting agent, something that causes a allergic response. Usually, sometimes it may be related to food, dust. Some patients have multiple. Then drugs obviously also is a known cause of allergy, and when the patients develop allergic reactions to these inciting agents, it don't necessarily mean that they have asthma. Now, asthma refers more specifically to a condition of the airways in the lungs, whereby there is chronic inflammation, and that typically manifests with the symptoms related to asthma, such as cough, phlegm production, wheezing, and it's known to be precipitated or made worse by a variety of reasons, such as respiratory tract infections or even emotional stressors. Specifically, some times, some specific allergens can trigger or worsen the symptoms of asthma, but per se, having allergies do not equate having asthma.
Okay. Yeah, thanks for the questions. So just now you're talking about emotional triggering. So I believe that most people will, let's say we've seen it in the movie or whatever. A lot of time when the subject in the movie, let's say they actually have a very strong emotional or anxiety attack, that could actually trigger the asthma attack. So is that true in real life?
So strong emotions or stressors at work have been shown to trigger, cause patients to have trigger or attacks of asthma. And yet, at the same time, some patients with anxiety disorders may have symptoms that sometimes seem to mimic asthma. And I think it is prudent to differentiate these two. Clearly, when the treatment is very different, because in asthma, we usually use medication specific to treat asthma. Obviously, if the patient has an anxiety disorder, at the same time, then the psychosocial aspects of it has to be addressed at the same time.
Yep. Okay. Thanks, Dr. Ip. So we already have some questions coming in, and I think it's not surprising. Actually, quite a number of questions is concerning the childhood asthma, because as I mentioned earlier, adult we got 5%, and actually even more children actually develop asthma at their childhood. So I think one of the key questions a lot of people is wondering, and some of the audience is asking, is whether childhood asthma. I think it's one of the very common concept that people will outgrow the asthma when they're growing into adulthood. So what is your thought on it? Does people really outgrow the asthma?
So I think to answer some of that concern is that first of all, asthma is not easy to diagnose in children, especially if they are very, very young. We look for features that suggest that they are asthmatic in terms of the typical symptoms such as cough and wheezing. If there are other associated diseases such as eczema or skin allergies or rhinitis or nose allergies kind of problems, and there's a strong family history. If the picture suggests that the patient has asthma, then we are typically more confident of it. But sometimes the diagnosis in a child can be challenging. A lot of the symptoms as the child with a history of asthma or symptoms suggestive of asthma grows up may actually resolve, and that is believed to be due to as the maturation of the lung, as you grow older, the airways are bigger, the lungs are more inflated, and a lot of the progress with development and the symptoms previously experienced as when they were younger abate. It is also true that as the patients grow older, their asthma can be come under control. But we always have to bear in mind that even if you have asthma with symptoms under control, with minimal symptoms, everything seems under control. At any point in your adulthood, they may still come back. It's just that asthma is a disease whereby the level of activity of the inflammation in the airway may change with time, and in future, even as they grow older and so-called grow out of it, it is still possible that they develop symptoms and attacks subsequently. We do know that patients or young adults or teenagers who have very persistent symptoms, that means their symptoms of asthma are always present and quite more severe. If they have associated eczema, features of atopy, then they are more likely to carry on into have this in adulthood.
Okay, so I think there's one very similar questions here. So let's say the patient is already sort of like you say, sort of like outgrown it at teenagers age, like 16, 18 years old. There's no asthma attack, but they actually still have some physical challenging, like when jumping and when going uphill, they still feel a little bit of breathlessness. Is that considered cured or actually outgrown the asthma already? Or actually there's still an underlying disease which is actually ongoing?
So I think it's if they continue to have symptoms, typically, as you mentioned, maybe related to exercise, then it is important for them to see a doctor and get it properly evaluated. I do see in my practice patients who seemingly are very minimal symptoms, but when they do come with some symptoms or on exertion, then when we do a lung function test, a blowing test, we can see that actually the degree of impairment or the reduction in their lung function can be quite marked. And most of the time, patients need a very major drop in their lung function before they start having symptoms. So if you lead a very simple sedentary life where you're just walking to and from work and sitting down on the computer, things like you may not actually have some of these symptoms of low lung function in asthma. And it's only something that we can pick up when we do a blowing test.
Okay.
But at the same time, we know that patients who have not have lower lung function, they in the long run, they are at greater risk of asthma attacks, what we call exacerbations. So we would, in some of these patients, we see they have minimal symptoms for very long, but they actually have lung function impairment. And then when we see them, we try to treat them and improve their lung function so that in the long run, they they don't get the impairment or exacerbation risk, or at least we can reduce that risk for them.
Okay, so maybe that's why when sometimes after, that's why people actually say after durations of maybe you are in 20 or 30s, actually you are getting fine, but when you're getting become an older adult, like 40-ish, asthma symptoms actually come back again. This might be a reason why you're explaining just now, right? So I think it's just the lung function actually deteriorating during this period, but it's sort of like asymptomatic because it's attack-free.
Yes. So they can be a period where it is what we call subclinical. It's not so evident that there might be some ongoing airway inflammation in asthma that is subclinical that we can't pick up. That means the patients usually don't have symptoms, and the impairment is not such that they will cause them to be breathless, and they're not having much cough. And in such settings, right, they can be missed. And only maybe when they have a exacerbation or a major attack that we do pick up that there is this condition that then we subsequently treat them.
Okay, so I think going back to the question just now, so for those particular patients, let's say they already have a periods of no asthma attack, but they're still actually experiencing some challenges in terms of physical activity. What is your recommendation in terms of exercising? Should they continue to do exercising, or they should actually know their limit and actually maybe tune down a little bit?
So a lot of patients with asthma tend to have what we call exercise-induced symptoms or exercise-induced bronchospasm. That means when they exercise, their symptoms typically would get worse. Usually described maybe 15 to 20 minutes after they start off their exercise. And in these patients, because exercise-induced asthma is very common, we would advise them that when you do the exercise, you need do a good warm-up, and then always remember to do proper cooling down. You should always increase your activity progressively to what you can tolerate. And at the same time, if symptoms still don't improve with this, we sometimes advise patients to use their asthma inhalers, their relievers, just prior to exercise to prevent them from getting the wheezing and the asthma symptoms during the exercise. We don't tell our patients not to exercise because regular exercise is, on the long run, beneficial to all patients for reducing their risk of heart disease and their risk of and help manage their high blood pressures and other reasons that are beneficial to the patient. So we advise patients to do exercise in moderation and not to refrain from exercising, and of course do the necessary steps that I mentioned earlier.
Okay, so there's one question on the swimming, because the audience, we now actually heard that people say that swimming actually help to alleviate the asthma. So is it true? Oh, in fact, is there any ideas exercise that is the best for asthma patients?
So it's very commonly actually recommended for patients who have asthma to swim if they as a form of exercise. I do it. I recommend it myself. The scientific basis is thought to be because when you're swimming, it's a higher humidity, and so it is less likely to cause tightening of your airways or wheezing or breathlessness associated with it. But other than that, I think any form of exercise works. There's actually no studies that suggest that this is superior or better for the patients. But we do, I think patients with, when you're swimming, you can probably, it is not a high impact sport. Patients who have asthma, I think most patients, is something that most patients are able to do.
Okay, so I think we need to tune back a little bit to our earlier discussion, because there's a question from Jeremiah. And the question is, because just now you mentioned it, diagnosing asthma in children is very challenging. So is there any obvious symptoms that the parents can actually observe for their children at home in case they are suspecting their children might actually have asthma?
Okay, so typically patients with kids with asthma is something you pick up when first they have an acute respiratory tract infection, because this is usually the most common thing that precipitates the asthma. And when they have the bout of the cold or a flu, running nose, cough, sometimes some fever, they start having wheezing symptoms. And this usually is alarm bells for us to think, oh no, does the child have asthma? After the acute respiratory infection is treated, their symptoms tend to improve. And then we look for repeated episodes, because asthma is something that usually comes repeatedly. And in between the episodes, we look for symptoms that suggest there is ongoing asthma disease, such as cough, phlegm production, wheezing, and breathlessness. These are obviously alarm bells that should trigger a parent to bring your child to go and see a doctor. At the same time, some clues that the child may also have asthma include other diseases that are associated with asthma, such as eczema, probably the most common, and allergic rhinitis or a sensitive nose.
Okay, noted on that. So, in terms of treatment options, there's one question from Rachel is whether someone could be too reliant on asthma on the inhalers.
Okay, so in asthma treatment, there are two main categories of medication that we use. There are the reliever medications, which are used only as required when they are having asthma attacks, and then the preventer medications or controllers. When it comes to the preventer and controller medications, they usually involve the use of inhaled corticosteroids, which reduce the airway inflammation and hence keep the disease at bay. Patients don't get dependent on this medication in that sense. It's not like an addiction or a dependency from, like, say, drugs of abuse. The dose of the medications and the preventers that we use should be adjusted according to the patient's symptoms and frequency of attacks. The aim of the doctor managing is always to use the lowest possible dose to keep the patient's disease under control. And whereas the relievers are concerned, because the intention is they are only meant to be used as and when required, and they should not also be cause a dependence or addiction.
Okay, so we understand that actually there is actually in the medical field, especially, there's actually always a concern that there's a overuse of the reliever. So, what is your opinions on that? And is that true? You see a lot of your patients actually over rely on the reliever.
Okay. So relievers are like what used when the patients are symptomatic, they are wheezing. They give the patient immediate relief of their symptoms. So patients immediately get within 5 minutes or so, get less breathless. But of concern, I think, in clinical practice these days is that, and studies have shown that patients who use a lot of relievers are at higher risk of getting worse asthma outcomes in terms of more major attacks require hospitalization and urgent medical care, and also even death from asthma. It is not so much that the reliever medication is bad or detrimental to the patient. Actually, what's the problem is that the patient is not using the relievers are temporizing measures, and the patients are not receiving at the same time treatment for their asthma. Now, treatment for the asthma requires the use of preventer medicines. And when they are only using reliever medication without the use of prevention medications, their disease could be progressing, the asthma could be worsening, and they could be getting more and more episodes of attack. For example, say he might have one episode of wheezing a day, it's going to 2 times, 3 times, 4 times a day, but every time the patient uses a reliever, his symptoms improve. But actually, the disease is actually worsening. And what you really need in these patients is that they need the preventer medications in terms of usually inhaled steroid inhalers that are used to suppress the disease and keep them under control. So the danger here these days is that the patients using a lot of reliever without concurrently using preventer medications risk worsening their disease, and this has been shown in several medical studies to be the case. Yeah. And so the current recommendations is that the patients should never be given a reliever alone. They should always be given concurrently with a preventer. This can be given either together in a single inhaler or in two separate inhalers.
Okay.
This is a strategy only applicable to patients who have milder asthma. In patients who have more severe asthma, they would really need to take their preventers on a regular basis.
Okay, so there's actually a very similar, actually the add-on questions I would say from Francisca, and it's actually about the how long does it take to actually evaluate the type of asthma, and actually how long you actually will consider to change the medication or drugs that you are using.
Sorry, what was the first question?
Okay, so it's actually is how long usually, I think the question is what is the durations for you to actually assess the asthma in terms of the development or the severity, and the duration before you decide to of evaluation before you change medications or drugs for the particular patients.
If the patient is on just recently diagnosed, we look out for symptoms of they should respond to the treatment in of course there is the acute and then the more chronic episode. During the acute phase of the illness, so let's say they are in exacerbation, we expect the treatment for the exacerbation to resolve in a few days. Then when the patients are out of the major attacks now, then when we are going into the more longer term management of the asthma and keeping the symptoms to minimal and reduce the patient's risks and improve their symptoms overall, then we would usually use medications for at least 3 months, typical preventer medications over 3 months to see whether the symptoms come under control before we consider reduction in the dosage of medications.
Okay, so in terms of using the inhalers or any other medications, in case the patient get pregnant during this journey, should they actually stop the medications or should they continue? So what is the advice on that?
We never advise patients on asthma to stop medication.
Okay.
They might require a review by their doctors for consideration or change or change in medication, or whether it is increase or decrease or a total change in the type of medication. But we will not advise patients to stop their medication abruptly. The basis of it is this: if the risk of asthma medications to the unborn child, the fetus, is generally very low, and it's much, much lower than the risk of a major attack in the mother to the child. When the mother sustains a major asthma attack and oxygen levels drop and your life's under danger, you are posing a much greater risk to the unborn child. Whereas the risk of medications to the fetus is really very small. These days, asthma medications, in terms of whether you are using just inhaled steroids or combination therapy, are mostly very safe in pregnancy. There are some drugs, of course, that have a longer track record that have been shown to be safe in pregnancy. Some drugs are newer, and so the track record is probably shorter. But I think most of them do not pose much risk in terms of abnormalities or malformations in the fetus. But this is something that you should always consider, always discuss with your doctor. We typically go by a rule of thirds when it comes to asthma and pregnancy. But 1/3 of patients with asthma, when they become pregnant, actually get worse and require an increase in their asthma medication. About 1/3 stay the same. That means their asthma remains under control. And the other 1/3, in fact, improve, and then their asthma symptoms actually reduce, or they get better control during pregnancy.
Okay. I think that actually explained that. I think the advice definitely is that, let's say, in case you get pregnant, you have asthma, don't actually stop any medication abruptly. Actually, always go back to discuss with your doctors. So the next question actually is very similar. I think it's a similar concern of the pregnant patients, is that in case the patients got asthma and they are actually having a child, so is there a higher tendency that the child will become asthmatic as well?
Asthma has been known to, the genetics of asthma is that it's been known to run in the family, but it is not a clear inheritance that is well known. Like, some conditions, if the parent has it, the child would have it, or has a 25% chance of having it. Some medical conditions are like that. In asthma, it is a very mixed bag. It's very complicated, much more complicated. Yes, there's a tendency to run in the family, but it is not something we can predict accurately. And even it's been known to what we call skip generations. Let's say your grandparent may have asthma, but then your parents may not have the asthma, and the grandchild may have the asthma, despite the fact that the parents are okay. So yes, I would say yes, if you have asthma, there's possibility of your child having asthma would be higher than the overall general population. But as a whole, asthma itself, the risk or the chances is not something we can accurately predict. Asthma is overall, as mentioned earlier, pretty common in the community. It's about 5% in adults. So chances are, it's already 1 in 20 chance that any adult in Singapore has asthma.
Okay, so I think we'll just move the discussion towards more of the trigger of asthma. So there's one question from the audience, that is there any common trigger, especially in terms of food and drinks? So what is your thoughts on that?
So the commonest triggers for asthma are typically acute respiratory tract infections, brought about by usually some viral infections. If other triggers of asthma may include other forms of illness at the same time, like a patient may be having for example, a lung infection or a kidney infection and admitted to hospital. And these other medical conditions can because of the stress on the body can trigger the asthma, especially the asthma baseline is not well controlled. Other symptoms, other things that can trigger or worsen asthma includes things like allergies, such as certain things that the patients might be allergic to. Commonly are like dust mites, the common dust mites, pets like pet fur, and sometimes food. There aren't specific food categories that are known to trigger asthma. It varies from patient to patient. Very commonly, what patients would tell me is like, "Oh, you can't eat oranges." That usually the citrus fruits are something that patients always mention. Other things that some are quite unique to Asians, this part of the world, is like bird's nests. And yeah, sometimes people tell me about chicken. Again, there aren't proper like scientific basis for it. Each patient would have to experience this and find out for themselves what triggers their symptoms.
Okay, so actually it's possible, but there's no scientific science to actually endorse any food or drink should be prevented. How about coldness? There's a similar question about winter trigger asthma. So does coldness could actually trigger asthma?
So changes in weather have been known to trigger asthma also symptoms, but again, there's also on a different note that there are some seasonal variations for some patients and their symptoms, especially in the more temperate countries which has the typical 4 seasons. Like, in spring where the flowers are blooming, there are pollens are in the air, and those pollens might trigger asthma attacks. In our part of the world, typically rainy seasons, cold weather. But also something that we have to bear in mind is that in cold times of the year, not so much in our part of the world, but in the temperate countries where there are winter, cold weather usually means that people stay indoors more. And when patients stay indoors more, whether it's in a mall or in a house, respiratory viruses are prevalent, and they can spread from people to people, and they can also cause acute respiratory tract infections that can trigger asthma.
Okay.
I think in Singapore, we don't particularly have a seasonal kind of asthma thing, with the exception, of course, of during the times of the year where the haze is a problem.
Okay. Yeah, I'm sure. So I think again for coldness is not really scientific proven, but something associated with the coldness, like you say, the pollen and also the high risk of cold or viral infection might be actually the culprit of this. Okay, so Dr. Ip, I think the next few question actually is what I was expect to come out already at the start is actually about the COVID, because I think this is a hot topic nowadays. So there are some questions from the audience. Is that let's say the patient already got asthma, is that do they actually have a higher risk of getting a COVID, or vice versa? Let's say they are actually asthma patients, they are asthmatic, let's say got the COVID, is it a higher chance that it will actually trigger the asthma exacerbations?
I think that if you have asthma, that shouldn't put you at a higher risk of getting COVID. I think COVID is something that is to do with close proximity to other infected individuals and being passed from patient to patient. It's like any other viral infection that can be easily passed by droplets. And that's something that we can reduce the risk with usual social distancing and hand hygiene. It's not been shown to be particularly more prevalent in asthma patients.
Okay.
However, there is, I believe the WHO does, or the CDC does give a general caution to asthma patients that if new patients with um, more severe asthma disease, if you do have COVID, then you are at risk of getting a worse disease, a more severe form of COVID-19. But that is just a general caution to doctors, so that to be aware that if a patient you are seeing with COVID-19 has a history of a more severe asthma, you just need to be very cautious and monitor him and treat him accordingly.
Okay. Yeah. So I think the next question is that whether the asthma, in case a patient got a childhood asthma, when they get older, would actually the symptom get worse? Or actually, one of the audience actually concerned about the higher risk of them to getting a COPD when they get old. So is there any scientific evidence behind this?
So asthma and COPD are two separate diseases. In COPD, it specifically refers to a disease, although in terms of symptoms and in terms of the clinical features that the patient have, they might be very similar. As a disease entity, they are separate. COPD appears most commonly in patients who smoke. It does sometimes appear in patients with other causes of inhaled fumes, but the majority of the patients are smokers. And that itself is distinct from asthma, which can appear in non-smokers also have. Obviously, there are a bunch of asthma patients that smoke, and so there is an overlap of this disease. But asthma patients, you don't become COPD just because you have severe asthma, but it's more likely that if your asthma is long-term under or not treated, right, and your lung function is poor and it is not treated for many years, over time you'll reach a point where despite how much treatment we give to the asthma patients, we are not able to reverse it and improve their lung function, and they start behaving like COPD patients, which means that their asthma symptoms are becoming like their asthma symptoms become like more chronic and more permanent, and they have features and symptoms more like the COPD patients.
Okay. Yeah, thanks, Dr. Ip. So we have actually last question on the list, and that is actually the audience actually concerning, let's say she is actually have asthma attack but without the inhalers. So what will be your recommendations here?
You mean like when you run out of a reliever, is it?
Yeah. Yeah, of course. Yeah. Run out of reliever, how happens when, let's say, the patient don't have the reliever inhaler on hand during the asthma attack?
Okay. First, I would advise the patient to stay calm, get help if it's available, or go if you can see if someone can around to help you get help. See if there's a medical facility nearby that you can get to. Otherwise, always stay calm. Do some deep breathing, sit up, do some deep breathing, exercise, and if there is something that's triggered the asthma attack, like there is a flower or pollen that that has triggered your symptoms, or a fumes, like someone is burning some incense vapor or something like that, then quickly move away from the possible trigger as fast as possible as you can, and try to get help.
Yeah, okay, thanks, Dr. Ip. So I think we are coming to actually 1:45 now. So I think to end out the sessions, I'm just wondering if Dr. Ip will have any final advice for the asthma patients on how you could actually improve your personal health asthma care, or general advice for asthma patients.
I think patients should take ownership of the asthma. They should know where this is their disease, and they should always be able to. They should manage their asthma disease themselves. What is recommended is that patient must have an action plan. An action plan that patients know what to do in times of when they have an attack, when they are having a severe attack, or when it's a normal day and they are sailing through it. The patient should always have what is an action plan. An action plan is also not something that's just something in your mind. It should be written down. And this is something that all patients should go and ask their doctor of it. What is my action plan, so that the doctor can tell you if you have these symptoms, what you should do, what you should increase your medication or decrease your medication, or if it's a major emergency, you should go and see a doctor quickly or call an ambulance, so that the patients are able to manage their asthma themselves. And these patients should also be regularly reviewed from time to time. You should see your doctor at least twice a year if you have asthma, so that they can review your progress, and if necessary, change your medications.
Okay, thanks a lot, Dr. Ip. I think that's a very good advice for actually all the asthma patients out there, to see how actually you yourself could actually improve your personal care, of course, together with the expert actually available here. Okay, so I think in lieu of the time, I will actually we will actually end the session here. So again, I would like to thank Dr. Ip again for actually spend his time for the past 40-50 minutes. And actually, I think there's a very good discussion sections with the audience, and I believe everyone actually will be benefited from these sections. Yeah. So to the audience as well, in case you have any other further questions, please feel free to actually send a private message to Mount Alvernia under the Facebook page. They will actually get your answer address offline as well. Okay. So
Thank you.
thanks, Dr. Ip again. Thanks everyone. See you.
Thank you. Bye.
Take care, everyone. Bye.